really apologize in advance for my raspy voice and what probably will be a meltdown of coughing up here. So just a heads up. So yeah, we're switching the topic to heart failure. This is the faculty involved in this presentation and our disclosures. The objectives we're going to talk about multiple times over when we go through the agenda. So there's 7 pretest questions, couple to start. There's no right answer to this one. Please rate your confidence in your ability to incorporate new therapies for heart failure into your clinical practice. Not at all confident, slightly confident, moderately, pretty much, or very. All right, next question. How often do you ensure that your heart failure patients are taking all the appropriate guideline-directed medical therapies? Never, rarely, sometimes often, or always? Okay, so here's our agenda today. We're going to talk about the types of heart failure and how to evaluate a patient with heart failure. And then the bulk of our discussion is going to go into patient management. What kind of treatments do we use for these patients? Predictors of poor outcomes, and then ultimately, how do we improve quality care and reduce readmission rates? So, just a couple of early slides to say, this is why we're talking about heart failure. Very prevalent. It's the #1 reason that the Medicare population comes into the hospital. It's very costly, as you can see. The mortality rate, despite all of our efforts, is still really high. It's worse than many cancers. So lots of good reasons to talk about heart failure. And you can see the projections through 2030 as we get better treating all forms of heart disease. And as the population continues to age, heart failure becomes more prevalent. And it's not equal in all races, as you can see here, particularly an issue for African Americans. So in regard to the types of heart failure, so the heart's a pump, right? It relaxes, it squeezes. It relaxes, it squeezes. So we predominantly see 2 types of heart failure. And there's a lot of other types of heart failure that we're not going to get into today. But predominantly, we're talking about patients that have reduced ejection fractions. We used to call that systolic heart failure, right? So the heart isn't squeezing well, and the left ventricle isn't pushing out the blood that it should. And that's considered heart failure with reduced EF. The other heart failure you will commonly see is heart failure with preserved EF. And that essentially means somebody has a normal EF. By the way, an ejection fraction normally is 55 to 65%-ish. That's how much blood gets ejected from the left ventricle. It's never 100%. So if you have clinical signs of heart failure and your EF's normal, then you go into that category. In the US, it's a 50-50 split. If you look at all comers that come into the hospital, it's pretty much 50-50. But almost all the therapies we're going to talk about today are going to focus on reduced EF, and that's because we really don't have therapies that have been proven to be efficacious in preserved EF. So having said that, next question is which level of EF on echo identifies heart failure and reduced EF? Less than or equal to 20%, less than or equal to 30%, less than or equal to 40%, or less than or equal to 50%.
And it's cold outside. I've got the month of May. Oh, I guess you say what can make me feel this way.
Okay, I didn't think we were showing answers, but I guess we are. Less than or equal to 4. Well, we're going to talk about the real answers later, so I'm not going to give that away. Essentially, if you think about the slide I just showed you, reduced EF, normal EF, look at the middle picture, heart failure with preserved EF. Look how tiny that opening for the left ventricle is. The heart can't fill with blood if the ventricle is thick and stiff. And that's patients with preserved EF. Reduced EF, on the bottom, you can see this big, baggy, what we call remodeled, dilated heart that doesn't pump well. Big difference between the two. So heart failure pathology affects the thickness of the wall, the ejection fraction. The answer to our prior question, what we consider for patients with reduced EF is less than or equal to 40%. Preserved EF is considered heart failure clinically with EFs above or equal to 50%, and everything in between, nobody really knows what to call, so we're just kind of calling that mid-range ejection fraction. So what do your patients come in with? I mean, you see this all the time. They're tired. They're not pumping out enough blood. They're not perfusing their periphery. They're not perfusing their brain. They're tired. They're dyspneic. They can't catch their breath. Their exercise tolerance is reduced, right? They fill up with fluid. They get congested. They get backwards flow, which is sort of an old term, but they do. They get congested with fluid, not just in the lungs, but in the belly, in the liver, in the spleen, and then sometimes all the way into their lower extremities. When you examine these patients, one of the most useful things to look at is jugular venous pressure. If somebody's congested with fluid, you're going to see elevated JVP. You may not see rales. You may not hear rales, excuse me. As opposed to acute heart failure, with chronic heart failure, often the lungs can be crystal clear and you could have 10, 20, 30 pounds of fluid. So don't be misled by that. Again, lots of signs and symptoms of that fluid in the belly or ascites. An S3 is very useful if you can pick that up. And you may or may not see lower extremity edema. In younger people in particular, you tend not to. When you're evaluating these people, you're going to look at them individually, but in general, you're going to get labs. Keep in mind, thyroid disease can cause a lot of heart failure. B-type natriuretic peptide, or BNP, is good to measure because that gives us a sense of whether people are congested. How many people measure BNP or pro-BNP level here? Some, okay. X-ray, ECG, without question, the most useful assessment is utilization of an echocardiogram. An echo is going to tell you what the EF is, what the valves look like, what the wall thickness looks like, and can actually measure pressures within the chamber of the heart. And then it is imperative that you consider whether the person could have coronary disease. Because in the US, coronary disease is the #1 cause of heart failure. So if there's any reason to consider that, then you're going to get an evaluation for ischemic heart disease. Now, how do we classify heart failure? So many years ago, we only used the New York Heart Association NYHA functional classification, which is a subjective classification. So if somebody tells you, hey, pretty much I could do whatever I want all day long, they're class 1. And for a patient that can't brush their teeth without gasping for air, they're class 4, and 2 and 3 are in between. That can change. Somebody comes in the ED, fluid overloaded, they're class 4. You diurese them, they may be class 2. But the more recent classification are by stages, and that's by the American Heart Association, and that's stage A through D. Those include A being patients at risk for heart failure. And anybody in primary care, if you guys are in primary care, you've got to target those patients. Think about the prevalence of heart failure. If you're going to have any effect on reducing that prevalence, you've got to get to these stage A patients at risk for heart failure. Stage B are people that have abnormal heart structure, but they're completely asymptomatic. Most of the patients we see are stage C. So they have both. They have symptoms, they have structural heart disease, and then D are really end-stage heart failure. You don't go backwards in stages. Once you get to B, C, D, you don't go backwards. All right, so why do we have heart failure? As I already mentioned, in the US, CAD is the #1 cause. For African Americans specifically, it's hypertension, and then a variety of other causes, including idiopathic, viral, thyroid-induced, peripartum, less valvular disease than we used to see because we tend to pick that up. And importantly, again, think of those risk factors because you see them in the office: hypertension, diabetes, family histories, alcohol, drug abuse, etc. Comorbids, the average patient with heart failure has almost 6 comorbids. So pay attention in primary care because you know those at-risk patients. In African Americans, as I mentioned, hypertension is the most common cause of heart failure. African Americans tend to get identified later in the stage of heart failure. They do worse. And I bring this up because just like other diseases, we have to pay attention to genetic differences and races. So those types of things should be popping into your head when you're seeing these patients. In addition, very importantly, endothelial dysfunction is common in heart failure. So in addition to the heart being a problem, the peripheral endothelial undergoes changes, and your blood vessels don't relax the way they're supposed to and dilate, okay? But that's especially common in African Americans. And this notation here of NO, that's not no, that's nitric oxide. The endothelial response to nitric oxide is more impaired in blacks than in other races. And we're going to talk about that specifically when you talk about the treatment of hydralazine and isosorbate dinitrate. So in these people that are hypertensive, they can take a couple of paths. And, again, you see this all the time. Patients come in hypertensive, diabetic, hyperlipidemic, obese, right? Those patients are constantly pushing blood out towards high pressures. Their left ventricle gets thick, stiff, like that picture I showed you. At that point in time, the heart's remodeled, but they're relatively asymptomatic. They're stage B. But then that progresses. They get true diastolic dysfunction. The LV doesn't relax. They start to get symptoms, and then they have overt heart failure. And we also see patients that develop coronary disease. They may smoke. They may have high cholesterol, diabetes. They may have a heart attack. Again, sometimes the patient can be asymptomatic at that point in time, but they start to remodel. Ultimately, they develop systolic dysfunction and then symptoms. In the end, they all develop the same types of symptoms. And you do see a little bit of crossover because some patients with hypertension can burn out, so to speak, and develop systolic dysfunction. So there's a little bit of crossover between the two. Now, I'm not going to say a lot about this, but clearly treat comorbids. Okay, you've got to keep diabetics under better glycemic control, and you've got to control hypertension. And if you do these things, you will reduce the risk of ever developing heart failure. Extremely important because you see a lot of or inappropriately treated hypertension out there. So needless to say, you may have heard in the last week that the AHA announced that the new guidelines for blood pressure cut is 130/80. Well, for patients with heart failure, it's been 130/80. So please, please keep those targets in mind. One other comorbid to discuss is diabetes. Now, you're going to hear a lot more about diabetes by diabetic experts. I am not a diabetic expert by any shape or form, but please keep in mind that diabetes is associated with a very increased risk of heart failure. Glycemic control is imperative because these people have significantly worse cardiovascular outcomes. So the better you can control their diabetes, target that A1C, the more you're going to improve or reduce cardiovascular risk. Now, I'm not going to talk a lot about diabetic treatments. You're going to hear a lot more about that. There are some treatments that we avoid in patients with heart failure. If you have advanced disease and you're retaining fluid, we have to avoid TZD sometimes. Metformin can be an issue with kidney function. Really, the spotlight these days is on the SGLT2 inhibitors because cardiovascular outcomes have been shown to be better with those drugs, and I suspect you'll be hearing a lot more about those in the future. Some of the other therapies, there's really a little bit of a mixed picture as to whether cardiovascular outcomes are better or not better or concerning for patients with heart failure. But the SGLT2 inhibitors, so again, I'm not a diabetic specialist, but these SGLT2 is responsible for the reabsorption of glucose in the proximal tubule of the kidney. So these drugs essentially make you pee out glucose, okay? They've been associated with very much improved cardiovascular outcomes. They've reduced blood pressure. They reduce weight. Lots of good outcomes. There are some downsides, of course. If you can imagine you're peeing out a lot of glucose, you can develop infections. You can auto-diurese and make somebody dehydrated, as well as some concerns with amputation risks with one of the drugs. But there are ongoing trials with these drugs looking at both patients with preserved EFs and reduced EFs. And the one comment I will make, well, I'll make three comments. One is control your patients with diabetes. They got to have glycemic control. Two, think about what therapies you're using if they have concurrent cardiovascular disease. And three, the more and more data that comes about that shows cardiovascular risks to either be improved or worsened with these drugs, I think you're going to see more cardiovascular providers wanting to weigh in on the treatments of diabetes. All right, so we talked about what a patient looks like when they come in with a heart failure, the types of patients that develop heart failure, and how we evaluate them. But what about the management? And this is really the meat of what we're going to talk about today. What drugs do we give, and what non-pharmacologic therapies do we give? And we're going to talk about both established therapies and new therapies. So the AHA, the ACC, and the HFA's guidelines are our Bible for heart failure. 2013 is the guideline, but it was updated in 2017, and it's actually undergoing revisions as we speak. But this truly is our reference and Bible for heart failure. So let's talk about the drugs that you all are using now. And again, when I talk about therapies, unless I say otherwise, I'm talking about therapies for people with reduced ejection fractions, not preserved. So increase attention to prevention. That's the stage A patient that anyone here in primary care is going to focus on. Once you have heart failure, your EF's reduced, we give patients what we call triple therapy. And unless you have a reason not to, all your patients should be on either an ACE inhibitor or an angiotensin receptor blocker, an ARB, an aldosterone antagonist or mineralocorticoid receptor antagonist, whatever term you want to use, and one of the efficacious beta blockers. There are newer therapies that have come out that we're going to talk about, ARNIs, angiotensin receptor neprilysin inhibitors, and ivabradine, which is a sinus node inhibitor. We'll get to those a little bit later. But unless there's a reason not to, your patients with reduced EFs should be on all three categories of those drugs. We're not going to spend really much time talking about CRT or ICDs, but implantable cardiac defibrillators do save lives and are indicated in class 2 to 3 patients. Cardiac resynchronization therapy has been shown to be efficacious not just in saving lives, but in reducing morbidity and hospitalizations in patients through class 4. We don't use a lot of digoxin anymore, and the reason for that, two reasons. One, dig has never been shown to save lives, and two, it's got a very narrow margin of safety. So you've got to keep your levels low, or you can cause more harm than good. Again, I'm going to talk a little bit about specific therapies for specific populations, including hydralazine isosorbide, and certainly everything and all about evidence-based therapies. So this is like a really good summary slide of what we use for patients with reduced EF. So let's just take a moment to go through this. So ACE or ARBs reduce morbidity, reduce mortality. We've been using these, literally the trials occurred in the late 80s. Whether it's an ACE or an ARB, we're going to use these therapies unless completely contraindicated. We're going to talk about, a little bit more later about ARNIs, angiotensin receptor neprilysin inhibitors. This slide's a little bit misleading. ARNIs actually have greater mortality effect on top of what ACE and ARBs have, so we'll get to that later. I cannot emphasize enough that beta blockers are the most important drugs you're giving your patients. Beta blockers not only save lives, but they actually can reverse that nasty remodeling process that you see in the heart. They can shrink up the left ventricle. They can improve ejection fractions. If you are on a tight budget and you've got one drug that you can afford to give your patient, it's probably going to be a beta blocker. Cannot emphasize that enough. Aldosterone antagonists have been shown to reduce morbidity and mortality. They reduce fibrosis, so we don't use them for their diuretic properties, but we use them for their neurohormonal properties, and they do save lives, and we'll talk about that later. So that's the triple therapy we talked about. Ivabradine we'll get to later. Sinus node inhibitor has been shown to reduce hospitalizations. Hydralazine and isosorbide dinitrate works on that endothelial function, specifically works better in African Americans than in other races and has a profound effect on mortality in African Americans. And then we talked about CRT and ICDs. All right, so let's just talk about a little, common sense things about these groups of drugs. So ACEs and ARBs, obviously they lower blood pressure. If you've got a patient with marginal blood pressure, you've got to be cautious. They work through the kidneys. If you have kidney dysfunction, you've got to be cautious. Everybody with heart failure almost has some type of renal insufficiency. You don't need to have a normal creatinine to use these drugs. You don't have to be afraid to use them. In general, rule of thumb, you can bump creatinine up to almost 30% without being so worried about it. So you will see a little bit of bump in creatinine. That's okay, but you've got to watch it. And you also have to watch the incidence of hyperkalemia because they do cause potassium retention. So you've got to monitor that, especially when you're adding this to an aldosterone antagonist, for example. If you're ACE intolerant from a cough or angioedema, you can flip to an ARB. If you're intolerant to both of those, then you could consider hydralazine and nitrates in any race. Less efficacious, but you could consider them. We don't really add ACE and ARBs together much. The data is not that strong, and you should not be using an ACE and ARB and an MRA. Too high incidence of adverse events, namely hyperkalemia and renal insufficiency. With any of these drugs, by the way, you're going to start at a low dose, and you're titrating slowly. Start low, go slow. Every couple of weeks, if you're not in a rush, you're going to titrate them up. That's the best way to do it to avoid side effects. Now, beta blockers, you're only going to use an evidence-based beta blocker. So if you have heart failure and reduced EF, that means bisoprolol, which is highly selective, metoprolol, also selective, or a totally non-selective beta blocker, which is carvedilol. Those are the only 3 beta blockers approved for the use in heart failure with reduced EF, none other. You're going to use them on top of an ACE or an ARB. This comment about first optimized fluid status. Keep in mind, and if you're my age or older, you might remember a time when we never used beta blockers in patients with heart failure because they said, you're going to put people into heart failure. And the reason they used to say that is because beta blockers reduce cardiac index, cardiac output. So when you first give them, especially if you give them a lot, you're actually potentially going to put that person into heart failure. That is why we start low and go slow with the dose. And you want your patient, when you're initiating a beta blocker or optimizing a beta blocker, to be in a relatively euvolemic state or relatively compensated. You don't want to throw beta blockers or raise beta blockers when somebody's decompensated. That's not the time. So start low, go slow. Most people, 95% of patients in my practice tolerate beta blockers. There are very few that really have severe reactive airway disease that can't tolerate it, or have symptomatic heart block or bradycardia and so on. But the large majority of patients are tolerant to beta blockers. And again, don't identify a patient as being beta blocker intolerant unless they really are, because their effect in heart failure is profound. All right, the third arm of the triple arm, aldosterone antagonist. We use a lot of spironolactone and eplerenone. Eplerenone's a more selective aldosterone antagonist than spironolactone, fewer side effects. We use these drugs, again, for their effect on neurohormones, on reducing fibrosis and keeping people alive longer, not really for their diuretic properties, although they do add to diuresis. Please keep in mind with these drugs that they have a profound effect on potassium and can cause hyperkalemia. You've got to watch that, especially in high-risk patients, which include patients with renal insufficiency and diabetes. So, when we first started using these drugs and they became approved with the indication for heart failure, there were phenomenal publications, one in particular that came out of Canada, that stated that patients were coming to the ED more with hyperkalemia and dying of hyperkalemia because clinicians were throwing on these drugs and not monitoring their serum creatinine and serum potassium levels. So please, use these drugs, but use them cautiously and monitor, and keep the patients on a low potassium diet. Now, we talked about, again, endothelial function in African Americans particularly. So years ago, there was a study that looked at ACE inhibitors versus hydralazine and nitrates for all comers in heart failure, particularly men, because it was a study done in the VA. And what it showed is that ACE inhibitors worked better. So way back a while ago, we kind of stopped using very much hydralazine and nitrates. And we said, you know what, ACE is better, let's use ACE. But many years later, it was identified in a retrospective analyses that for some reason, blacks seem to do better with the hydralazine and isosorbide dinitrate than the ACE inhibitors. So they went back and they did this big trial called AHEFT. AHEFT is a trial that only included blacks, that added hydralazine and isosorbide dinitrate on top of ACE, ARB, or beta blockers and MRAs. And it showed this profound 43% reduction in mortality in blacks with reduced EFs. The trial included patients with class 3 and 4 heart failure, reduced EFs, reduced hospitalizations, improved quality of life. Again, it's through this peripheral endothelial mechanism through nitric oxide. So please, if you have an African American with advanced heart failure, they should be on this drug. Not always the easiest thing to tolerate because of the vasodilatory properties, the reduced blood pressure, the dizziness. Again, start low, go slow. As a result of this trial, the drugs are included in the current guidelines for heart failure. Now, just like we have drugs that we've got to use, we have drugs that we really don't want to use. We talked about diabetic therapies. Thank God I don't have heart failure because Sudafed's something that I'm using right now. What about NSAIDs? You ever go into Rite Aid? The whole aisle is filled with NSAIDs: Motrin, Aleve, Naproxen, ibuprofen, everything under the sun. Not only do our patients use these constantly, but physicians or providers prescribe these constantly. They're terrible drugs. They are totally contraindicated for patients with heart failure. They cause fluid retention and kidney failure and other cardiovascular risks, including MI. No NSAIDs for these patients, unfortunately. Antiarrhythmics, we use very few. Amiodarone's an okay drug to use. I won't get into all the details of that, but there are issues with many antiarrhythmics. We do, of course, use inotropes in patients with heart failure. But anybody here work inpatient? Not that many. Okay. And, if a patient comes in the hospital and they're in a cardiogenic shock, they need an inotrope. If you need to bridge time between that decompensation and transplant, you could put them on an inotrope. Or if they're at end stage and you're using inotropes for palliative care, that's okay. But any other patient should not be on an inotrope. So if somebody comes in the hospital and they're fluid overloaded, then you diurese them, but you don't give them an inotrope because inotropes are associated with higher morbidity and mortality. All right, so we talked about all established therapies that we are all using. What about a couple of new therapies that more recently got approved for heart failure? So here's a question. 66-year-old black male presents with progressive dyspnea, history of MI, COPD, hypertension, and dyslipidemia. Common guy in your practice, right? On exam, BP is marginal, 95/70, heart rate 88. I think that's supposed to be HR, not PR. Sinus rhythm, occasional wheezing, a little bit of edema, and an echo EF of 30%. He's on lisinopril, aspirin, atorvastatin, metoprolol, furosemide, hydralazine and nitrates, and an inhaler. Previous attempts to increase the dose of metoprolol led to fatigue and dyspnea, so it doesn't sound like we're going to up our beta blocker. Which of the following might be appropriate at this time? So, should we add avabradine? Should we increase lisinopril to 80? Admit for IV diuresis? Or add an inhaled bronchodilator or corticosteroid therapy? Time to answer. God, for these questions, gives me a breathing break and a water break here. All right. So anybody here using avabradine? Not really. Okay. Avabradine is a relatively new, it is a new drug. The brand name, just so you know, is Corlinor. So you may, identify with that more easily. It's the only drug of its class out there. It's a sinus node inhibitor. It slows heart rate. There's data to show that if you have heart failure and you run a particularly high heart rate, you actually do worse. So there is some thought about slowing the heart rate down. This drug was studied in a landmark trial called SHIFT. SHIFT took patients predominantly with class 2 and 3 heart failure, reduced EF, in normal sinus rhythm, who had heart rates of 70 or above. And patients were randomized to avabradine or placebo. And what they showed was an 18% improvement in the composite endpoint of cardiovascular death and hospitalization for heart failure with patients with heart failure and reduced EF. Now, let me just tell you, because it's not obvious from this slide, in all fairness, this was primarily driven by reduced hospitalization for heart failure, not by death reduction. So this drug actually it did have a positive effect on mortality, but not statistically significant. So I don't want to mislead you. So the drug, therefore, was approved by the FDA to reduce hospitalizations for patients with heart failure in the category that I just described, which included those patients in the study. So it is a drug to consider if you have a patient that meets that criteria. Couple of things to think about. It's contraindicated in patients acutely decompensated with a low BP only because it wasn't studied in those patients. This drug actually increases BP. It doesn't reduce BP. You clearly want a heart rate of 70 or above. If your heart rate's below 60, you shouldn't be adding this drug. If you're pacemaker dependent, not going to work. And if you're already in heart block, you don't want to give it. It is processed through the liver, so keep that in mind. You also want to keep in mind that side effects, some things you are common sense, right? Bradycardia, for example. I told you it can increase blood pressure. There was a slightly increased incidence of atrial fibrillation. The most interesting side effect are these phosphines. So this drug works through something called the F channels in the heart, funny channels, and apparently they're also in the eyes. So you can see some visual abnormalities with this drug that can be transient, and it can actually be affected by dosing, but sometimes not. One thing that I really want to, before I get to the next question, I would just want to say, do not reduce a beta blocker to get that drug on board, okay? You only add that on top of maximal tolerated beta blockers. All right, next question. 72-year-old white woman presents with peripheral edema, dyspnea, class 3 heart failure with low EF, recently hospitalized for heart failure, BP 132/78, heart rate 68, sinus rhythm, and edema. She's on valsartan, aspirin, she's on a statin, metoprolol, furosemide, and a eplerenone. What do you want to add to this? Do you want to add a avabradine, an ACE inhibitor, hydralazine and isosorbide, or you want to replace the valsartan with sacubitril valsartan?
Into your eyes, it's like watching the night sky or a beautiful sunrise. Oh, there's so much they hold, and just like them all.
All right, anybody here using sacubitril valsartan and Entresto? A little bit, okay, not too much. But, all right, so up top, you see the neurohormones in heart failure that we want to block. They're the bad guys, right? Those neurohormones, predominantly angiotensin 2, they vasoconstrict, they cause salt and water retention. We give an ACE or an ARB to block that pathway. But there's a good set of natriuretic peptides and neurohormones that we want around. And those are the ones you see on the bottom. The most common one is B-type natriuretic peptide. That's secreted from the ventricle when it's stretched and under pressure and overload. And BNP and the other natriuretic peptides of its type cause vasodilation, salt and water loss. It's a good guy. We want to keep that around. So if we can do that by blocking something called neprilysin or NEP. NEP increases the degradation of those natriuretic peptides. So if you block it using sacubitril, you keep those neurohormones, those natriuretic peptides around longer. So this drug blocks the bad and enhances the good. And that's essentially how it works beyond an ACE or an ARB. So you may have heard of the trial called Paradigm. Paradigm is a huge trial, the largest heart failure trial, included over 8,000 patients with predominantly class 2 and 3 heart failure, reduced EF. What they did was they looked at this group of patients, and 50% of patients received enalapril, and the other percentage of patients received sacubitril valsartan. So patients were on all background therapies with beta blockers, MRAs, et cetera. And then they were either randomized to get enalapril or sacubitril valsartan. And what they showed was a profound 20% reduction in the combined endpoint of cardiovascular mortality and hospitalizations for heart failure. That's pretty huge, because you're talking about comparing high standard therapy and using a new drug and showing this profound outcome. And it was really split between the two. The effects on hospitalization and mortality were both 20%, including all-cause mortality. So quite an impressive study. It was approved by the FDA a couple years ago to use in patients with class 2 and 3 heart failure and reduced EF. And the recommendation is to replace an ACE or an ARB unless contraindicated with this drug. And we actually do this all the time now. So a couple of notes on this drug. There's 3 doses. We tend to, when we're switching from an ACE, you have to wash out the ACE, because ACE can cause angioedema and so can this drug. So you want to wash out an ACE inhibitor for 36 hours before you switch. If they're on an ARB, you just stop it and switch. You tend to flip to the mid-dose. Unless people at higher risk, you may start at lower doses. And then you slowly titrate up every couple of weeks. Just like an ACE or an ARB, you're going to monitor blood pressure, you're going to monitor renal parameters, no different. The side effects of this drug, just like an ACE or an ARB, lowers blood pressure. In fact, this has more effect on blood pressure than an ACE or an ARB. Fetal toxicity, so you're not going to use it in pregnant women. Hyperkalemia, of course. same as an ACE or an ARB. In fact, the incidence of hyperkalemia and renal dysfunction was a little bit better using the combined therapy than just an ACE inhibitor. And the incidence of angioedema was not statistically different between the two, but keep in mind that angioedema is commonly seen more commonly, that's said that twice, but it's commonly seen more in blacks, okay? So a very important therapy that we're using now. I will tell you that the drug can cause a little bit of diuresis. So in general, think about reducing the loop diuretic when you introduce this drug. All right, what about non-drug therapies? Weight. Interestingly, we have something called the obesity paradox in heart failure. If you have a little bit of extra weight, that's actually not a bad thing. So to the far left here, if you're cachectic, that's not good. You can develop tissue wasting, protein loss, what we call cardiac cachexia, which is associated with worse cardiovascular outcomes. If you're morbidly obese with a BMI above 40, you do worse. But everybody in between actually does better, even if you have a little extra weight. For the morbidly obese, we do refer patients for bariatric surgery. So weight is something to consider along with other of those comorbids that we talked about. Sleep apnea is common in heart failure. It should be treated. We see particularly obstructive sleep apnea, but there is a high incidence of central. Some therapies are of concern. So seroadaptive ventilation has been shown to actually worsen outcomes. But there is a recommendation to use CPAP or BiPAP for your patients with obstructive sleep apnea. The hard endpoints of reducing mortality or hard cardiovascular outcomes are not out there, but you can make your patient feel better. You can improve sleep quality and certainly daytime sleepiness. So we send lots of patients for sleep studies. Now, interestingly, for all the time we spend talking about diet with patients, I'm only going to show you one slide on this. And the reason for that is because we really don't have good data to support these salt-restricted diets we put patients on. Yes, we restrict salt in most of our patients. By and large, we usually recommend a 2-gram low-sodium diet. It's particularly important in patients that retain a lot of fluid, that are diuretic resistant, right? But in some patients, they actually can get away with taking a fair amount of salt without an issue. Again, we are lacking substantial data, but we do put patients on low-sodium diets, as you're well aware. And it's a challenge. What about fluid restriction? This really should say fluid and not just water restriction. We don't recommend fluid restriction for anybody and everybody that has heart failure. So if you are, again, if you're retaining a lot of fluid, or if you have hypervolemic hyponatremia, then we suggest being on a low volume restriction. But other than those types of patients, we don't chase after patients about fluid restrictions, okay? So we reserve it for people that really need it. Now, it's not lunchtime yet, but alcohol consumption. Alcohol consumption actually isn't a no-no. It is break soon, right? So maybe mimosas. But you actually, a little bit of alcohol is okay, about a drink a day. But if you have a patient that has an alcoholic-induced cardiomyopathy, no alcohol, okay? So that's a common question that comes up for patients. Iron supplements, we see a lot of anemia in patients with heart failure. Interestingly, it's not just anemia of chronic disease, but it's iron deficient anemia. The studies have shown benefits for using IV iron, not so much for oral iron. This study that's listed on the bottom, Iron Out HF, really another not so positive trial. So IV iron is indicated. It's actually in the guidelines now. You can see here the use, if you really are iron deficient anemic, you can use IV iron to reduce symptoms and improve functional status and quality of life, but not hard endpoints. And years ago, we played around a little bit with using erythropoietin stimulating agents for our patients. Actually, the data has shown that not only does it not help, but in some instances, it actually makes things worse. So we're not using those therapies for our patients. All right, the last, I think the last category in this group of treatments includes exercise. Exercise is good for your patients. Are they going to run the New York Marathon? Highly unlikely. But when I say exercise, if you have a class 3 patient and they can walk a quarter of a block and rest, then they should do that. If they can walk a half a block or a block and rest and then get up and walk again, they've got to do that. If they can walk across the room instead of sitting on the couch with their clicker, then they've got to do that. Remember what when I talked about the peripheral endothelium and heart failure? The less people walk and are active and exercise, the worse that peripheral endothelium gets. So you've got to keep your patients active. And actually, there was a large trial called ACTION-HF. It was an NIH trial that had positive outcomes when utilizing cardiac rehab for patients with heart failure and reduced EFs, improved exercise duration, quality of life, and mortality. So CMS, Medicare, has actually approved cardiac rehab for patients with heart failure and these specific criteria, class 2 to 4, on good therapies, relatively stable, low EF. So please, we refer almost all of our patients. The biggest problem with cardiac rehab is the patient getting there 3 times a week. All right, we're going to move on to, we talked about the types of heart failure. We talked about how to evaluate our patients, the good drugs that we give them, both old and new, and the non-pharmacotherapies that we use. What about predictors of poor outcomes? Now, I would rename this, our characteristics of high versus low risk patients. Because I think, particularly for those in primary care, how many people here are in primary care? Okay, fair number. You need to identify a patient that's low risk, that you shouldn't have to give a lot of attention to in the hospital or out, or a patient that's high risk that you really have to give a lot of attention to. So I'm going to kind of rename this little section here. So first question, in a large clinical trial, which of the following were found to be significant independent predictors of mortality and heart failure? White race, female sex, low GFR, or a higher BMI?
I don't practice Santeria. I ain't got no crystal ball. I had $1 million, but I'd spend it all if I could find that Hannah in that Sancho that she's bound. Well, I'd pop a cap in Sancho.
All right, so what are the predictors of higher mortality and heart failure? This study, GCHF, includes quite a big number, as you can see, of patients with heart failure and reduced EF. And the 3 top predictors of worse outcomes included older age, higher NYHA class, so worse functional capacity, and lower GFR. And I can tell you that there are other characteristics, including diabetes, lower BMI we talked about, diabetes, other risk factors that are associated with worse outcomes. But we see these common themes in our patients over and over again. If you're trying to identify a low from high-risk patient, think about using biomarkers. So not a lot of people, but some were using NT-proBNP or BNP. You can risk stratify patients by BNP, in the office and in the hospital as well. So definitely something to think about. The new guidelines, I don't know how well you can see this, but the new guidelines actually do focus on biomarkers. So if you have a patient in your office or in the hospital that is at risk for heart failure, which means they're diabetic, they're hyperlipidemic, they're obese, they're hypertensive, like almost every one of the patients you see. If they're at risk for heart failure, you should measure their BNP or proBNP level to risk stratify them. Because if they're elevated, then you have to think, maybe I need to do another test and make sure they don't have structural heart disease. In ambulatory patients that come to see you that are dysmic, you absolutely should be checking a BNP level, because BNP levels that are elevated in the setting of dyspnea are highly suggestive of heart failure. If the BNP is completely normal or low, unlikely it's going to be heart failure. And there are some exceptions to this, but in general, we don't really have time to get into the entire biomarker talk today, but very useful to risk stratify patients. If your patient actively has heart failure, class 2 to 4, you should be measuring BNP levels. There are other biomarkers you can measure, particularly in the hospital. You can look at troponin. Troponin's been associated with worse outcomes, and other markers of fibrosis. But BNP or proBNP should be measured. If somebody comes into the ED, without question, if they're dysmic, you measure a BNP or proBNP level. Again, if it's very low, highly unlikely they have heart failure. If it's elevated, highly likely they have heart failure. You risk stratify these patients. Also, you want to look at the admission BNP, and then if they get admitted and they get diuresed, you want to look at the discharge BNP. If the BNP or proBNP level, there's 2 different assays you can use. Some hospitals use BNP, some pro. If the BNP level on discharge hasn't substantially dropped, you better think again if that patient's been optimized. okay? Because discharging a patient with worse or not much better BNP is associated with worse outcomes. All right, so we're moving on to our last section. Improving quality care and reducing admissions for heart failure. I think most of us here know that heart failure readmission rates are being looked at very closely in the United States. CMS is essentially penalizing us. If your readmission rate's too high, you lose a lot of Medicare dollars. And every hospital in the country is under the gun for this. The readmission rate for heart failure in the country is high. It's 23% the last I checked. So, 1 in 3 of your patients is going to be back in the hospital in a month. And that translates, as I showed you to the very first slide, to a lot of utilization of health care dollars. So tremendous focus on reducing readmission rates. You can see from both of these slides, most of these admissions come early on or later on. So when we first get diagnosed with heart failure, we see a lot of readmissions, and then in the end or